In this second session on shock, we're going to look at the pathophysiology behind it in a little bit more detail. And as we do that, we'll start to underline some of the signs and symptoms of shock. And we talked about how heart rate starts to go up and breathing rate starts to go up previously, and how blood pressure starts to go down. But we'll also talk about the associated compensatory mechanisms that kick in. And as you can imagine, shock is a type of stress. So you can start to think that the sympathetic nervous system is obviously going to kick in during this point. So the signs and symptoms, if we're thinking about it, it's all about the inadequate systemic oxygen delivery to tissues. And that can have multiple effects in multiple organs. So of course, generalized wise, as you get decreased oxygen delivery to multiple tissues, you get generalized cell hypoxia. And therefore, you're starting to get widespread impairment of cell metabolism, leading to reduced ATP. You'll get a buildup of lactic acid, of course, as you're starting to work more anaerobically. And you start to lead to tissue damage, organ failure, and eventually leading into death. Most of the signs and symptoms of shock are due to the compensatory mechanisms of the cardiovascular system, because at the end of the day, the aim is to maintain a suitable blood pressure for life and to control blood flow and control the delivery of nutrients and the removal of waste products. But in severe shock, additional reflexes are activated at the very low blood pressures, and all types of shock eventually result in impaired tissue perfusion and acute circulatory failure or shock syndrome. So in the initial stages of shock, the tissues become underperfused. You get a decrease in your cardiac output because of whatever form of shock that might be, whether it's vasodilatory shock and therefore decreased venous return, reducing cardiac output, or it's a cardiogenic issue. Whatever the cause may be, you get that tissues are underperfused, you get that decrease in cardiac output, you get an increase in anaerobic metabolism, and you get a buildup of lactic acid. And the early compensatory stages, we start to activate our sympathetic nervous system due to that low cardiac output. And we're thinking about baroreceptor reflexes at this point. And so this is obviously reversible. We then move into what's called the progressive stage. So we've gone the initial stage, we've then gone compensatory. Now we're going progressive. This is where your compensatory mechanisms begin to fail. In other words, they can't fully compensate and they're struggling. You get profound vasoconstriction from the sympathetic nervous system induced ischemia, and you start to get lactic acid production at very high levels, leading to a metabolic acidosis. And then when you get to the irreversible or decompensated stage, you're starting to get cellular necrosis, so cell death. Multi-organ dysfunction syndrome may also occur at this stage. So now we're going to go through each of those stages in turn. So we'll start with the initial stages of shock. And this is where our tissues are underperfused. We've got a decrease in our cardiac output, if you remember. We've got an increase in anaerobic metabolism leading to lactic acid and decreased ATP levels, meaning our iron pumps stop functioning as efficiently. And so the sodium-potassium pump is one of the largest consumers of ATP in the cell, and its malfunction in the end starts to lead to a loss of membrane potential. At this point, though, it's reversible, and we may only be getting mild effects. So if we're taking a look at what's going on in terms of cellular damage, we're getting a decrease in our tissue perfusion. We get cell hypoxia, stimulating anaerobic metabolism. We get a reduction in the amount of ATP we can produce because less oxygen and nutrients are coming in. We're working anaerobically, we're producing less ATP, and we get an impairment of the sodium-potassium pump. And as I said, that's one of the largest consumers of ATP in the cell. And its malfunction leads to an increase in sodium and chloride within the cell and, of course, potassium efflux, and therefore cell damage due to the loss of the membrane potential, i.e. that negative charge. Therefore, cardiac cells and neurons are the most severely affected. So like I said, we're getting sodium influx, potassium efflux, loss of membrane potential, cell damage, mitochondrial damage, and cell death eventually. And of course, we're getting osmosis because of these changes. So we're getting that sodium coming in, the water coming in, and the chloride coming in, leading to osmosis. The cells begin to swell up, as you might expect, leading to cellular edema and mitochondrial damage and cell death. The other important part about this, of course, is as the cells are swelling because of that water influx into them, fluid is leaving the interstitial fluid and therefore the blood, and therefore reducing the effective circulating blood volume. And cellular edema just in itself it damages cellular membranes. It helps or it stimulates the release of lysosomal contents that can injure the cells internally, but also that can leak into the interstitium, causing damage in that area too. And as we've already talked about, we also have a decrease in ATP, and that impairs sodium-calcium pumps that are impaired. That leads to mitochondrial dysfunction because of calcium influx, and again, leading to that mitochondrial cell damage. So all of these things are working hand in hand together. And the other thing, of course, is that lactic acid in itself, that increases the permeability of membranes as well as affecting ion pumps. So there are multiple mechanisms going on when you get decreased tissue perfusion that eventually starts to lead to mitochondrial damage and cell death. And now we move on from the initial stages and into the compensatory stage. And so this is where we're now starting to get a drop in our blood pressure. This is detected obviously at the hypothalamus. We're getting baroreceptor inhibition of ADH release, which means we're getting first center stimulation ADH release, which tries to increase our blood volume and blood pressure. Remembering, of course, that ADH does multiple things. So ADH also causes vasoconstriction. So as we've also said, there's that drop in blood pressure. We have the baroreceptor reflex, increasing our heart rate, leading to this weak, potentially thready pulse. And initially, and in mild shock, that should actually maintain the mean blood pressure, because in those early stages, you can sufficiently compensate it. So that helps to maintain heart and brain perfusion. And as we've said, that drop in blood pressure through a couple of mechanisms. So you've got the baroreceptor reflex, causes peripheral vasoconstriction and venoconstriction. And also you've got ADH causing vasoconstriction in itself. Like I said, remember, that's a very powerful vasoconstrictor as well. And together that is also helping to increase that blood pressure because of that peripheral vasoconstriction. So we're increasing blood pressure and we're increasing blood volume through this mechanism. But a good key question is really, bearing in mind that we've got these phases of shock, and this is a compensatory stage and it's helping to maintain blood pressure, do you think arterial blood pressure is a particularly good measure of the extent of blood loss, for example, in particular in these early stages? So as you might expect in mild shock, there may be no reduction in blood pressure, as we've just been talking about, because of these compensatory measures. So potentially arterial blood pressure is not necessarily a good indicator of the extent of blood loss, in particular in those early stages. So there are a wide range of other systemic effects of shock, as you might expect. And we've got this baroreceptor activation of stimulating the sympathetic nervous system, and of course it's a stressful situation. And so just thinking about it, what are some of the things that will happen because of this sympathetic nervous system activation and the release of adrenaline as well, of course. So take a look at this table and complete it. So we're just saying what's happening at the pupil, what's happening to saliva, sweat, what's happening at the heart, blood vessels, etc. So press pause, have a little bit of a think about and a reminder of what the sympathetic nervous system does. Okay, so it causes dilation of the pupil. We get a thick viscous secretion of saliva, so it's really, very thick, not nice and runny. You're obviously going to stimulate copious amounts of sweating, so this is a byproduct, not a particularly useful thing to be happening during shock, because obviously you don't want to be losing fluid if you're losing it elsewhere, and in particular if that's the cause of it. So you don't want that blood volume dropping, but sweat does do that. It's not a particularly useful byproduct. But the heart increases heart rate and stroke volume to increase cardiac output. We're getting vasoconstriction to the blood vessels, except essential organs such as the heart and brain. Respiration, we're dilating the bronchi. GI tract, we decrease motility and secretions, and we've got decreased blood going there as well, remember, because of that vasoconstriction. At the adrenal medulla, we're stimulating the release of adrenaline, and at the kidneys, we're stimulating the release of renin because of this drop in renal perfusion, a reduction in GFR, and therefore the granular cells detect this and release renin to try and stimulate the renin-angiotensin-aldosterone system, and therefore help maintain blood pressure and blood volume. And adrenaline in itself, that will cause increased heart rate and stroke volume, causes bronchodilation, stimulates glycogen breakdown, so you can use that as an energy source, and stimulates glycolysis to stimulate the use of that energy. And of course, it stimulates lipolysis, so we can use fatty acids as an energy source as well. So there are a wide range of other systemic effects of shock, like we've talked about. And another one of these is peripheral vasoconstriction. And we've talked about the mechanisms of that. You've got angiotensin 2, which is involved in it, and we talked about how renin is released, so that's the renin-angiotensin aldosterone system. And we also talked about how ADH is a powerful vasoconstrictor as well when it's released. And these together lead to a reduction. So that peripheral vasoconstriction that we've talked about leads to that reduction in renal perfusion, decreased GFR, and that activation of the renin-angiotensin aldosterone system. Remembering, of course, that the kidneys are also innervated by the sympathetic nervous system and can also help to activate the RAAS. And through this entire pathway, and I've already talked about this already, so it's kind of just regurgitating the same stuff. Angiotensin 2 stimulates thirst, stimulates polydipsia, so drinking, stimulates vasoconstriction, or the desire to drink at least, vasoconstriction, increased sympathetic activity, ADH release. Aldosterone obviously stimulates renal sodium reabsorption. And ADH, if you remember, also stimulates vasoconstriction. And angiotensin 2 also stimulates sodium reabsorption in the proximal tubules. So there are lots of things going on that are trying to work in concert together to maintain that blood volume and to maintain that blood pressure. But overall, all of these things all lead to oliguria, so a reduction in the amount of urine production. And as we talked about previously, as the stages of shock progress, you produce less and less urine until eventually become anuric. So we've already talked about this as well. So the sympathetic nervous system causes an increase in sweating, but also vasoconstriction at the skin. So the skin feels cool and wet and doesn't evaporate. So the patient is feeling cold and clammy. And in terms of peripheral vasoconstriction, the skin can show a pallor and the lips may appear cyanotic. But it's also important to think, how might the patient feel if they were in vasodilatory shock, for example? Because the patient may not feel cold and clammy in vasodilatory shock because vasodilation predominates in that type of shock. So here's a summary of some of the compensation mechanisms that take place following shock. So the problem, so you might want to actually think about this actually. So think about what the compensatory mechanism is to the reduced blood volume, reduced blood pressure, hypoxia, and lactic acidosis. So with a reduction in blood volume, we activate the renin-angiotensin aldosterone system, and we start to feel thirsty, whether you can drink or not is a different matter. With the reduced blood volume, we're getting an increase in heart rate, blood pressure, we're getting an increase in heart rate, vasoconstriction. With our hypoxia, we get an increase in breathing rate and depth. And our lactic acidosis, we get an increase in breathing rate and depth. So we're getting that respiratory compensation for a lactic acidosis as we try and blow off that CO2. Neurons are also depressed, which leads to restlessness and potentially unconsciousness and coma. And then if we look at the next one, we're thinking about, here's the compensation mechanism that is going on. So we've just talked about these compensation mechanisms. And now what are some of the symptoms? Well, the increased heart rate leads to that weak, thready pulse. The vasoconstriction can lead to that cold skin, pale skin, blue cyanotic lips. Sympathetic activation of the skin. You can feel all sweat, it's clammy because it doesn't evaporate, remember, because you've got vasoconstriction there, so you don't have that heat gradient to help that evaporation. And you've got that water retention leading to oliguria. So there you're starting to see how some of the symptoms and the compensation mechanisms are all linked hand in hand. And what are some of the long-term compensations? So with your fluid loss, of course, you've got angiotensin 2, you've got thirst, you've got ADH, and you've got aldosterone. With your plasma proteins being lost, you start to make more proteins, so albumin synthesis, and these are long-term compensations, obviously. And with hypoxia, you'd be thinking about EPO synthesis and release, and remember that's released from the kidneys. So we'll just take another little look at this, so some of those systemic effects of shock. So if you have an increase in your anaerobic respiration, you're producing more lactic acid. It reduces glycolysis just through its inhibitory processes, means you produce less ATP, which means you have reduced myocardial function, which means you have a reduction in cardiac output. I was about to say carbon monoxide there, that wouldn't have been very smart, would it? You also get a metabolic acidosis, which is inhibits neurons, leading to restlessness and CNS depression. It also leads to a drop in pH, stimulating the medulla chemoreceptors, which has a minor effect on the CV center, but it becomes activated. But it also activates the respiratory centers, increasing the rate and depth of breathing, blowing off carbon dioxide, therefore trying to bring that pH back up into the normal range. So you're trying to compensate for that metabolic acidosis. And so as you move into the progressive stage of shock, the compensatory mechanisms begin to fail. And you're getting profound vasoconstriction from the sympathetic nervous system induced ischemia. Blood pressure drops despite this extensive vasoconstriction. So you're getting, but despite the extensive vasoconstriction, the increased heart rate and the fluid retention. The lactic acid production becomes excessive, which can't be compensated for by the respiratory rate and depth. So in other words, you start to get an uncompensated metabolic lactic acidosis, or in other words, your body can't fully compensate for it. So that metabolic acidosis develops, and that obviously leads to poor cell functioning, eventually onto cell death. And of course, due to that neuronal damage, can lead to unconsciousness and eventually coma. And then we finally hit that irreversible stage of shock. And this is where blood pressure can no longer be maintained by the variety of compensatory mechanisms that we have. So your drop in blood pressure becomes very significant. So the systolic down to 50 to 70 millimeters of mercury. That means we're not getting our cardiac output out, so we're getting reduced heart and reduced brain perfusion, which of course means we're getting reduced heart contractility because there isn't enough energy getting there to be able to feed that heart muscle, leading to a reduced cardiac output, which further reduces blood pressure. So it's this vicious cycle again, reducing blood pressure and further reducing tissue perfusion. We also have that reduced heart and brain perfusion, meaning we're having vasomotor neuron depression. And as we're getting that vasomotor neuron depression, we're of course getting a decrease in our sympathetic discharge, meaning we're now getting less vasoconstriction and we're getting less stimulation of our hearts. We're getting less of an increase in heart rate. So in other words, we're getting more of a vasodilatory and a reduction in heart rate effect, which of course, by their very nature, reduce blood pressure, reducing blood volume and blood pressure further, which again is very significant. We then get due to this drop in blood pressure, we're now getting a minimal perfusion in our peripheral tissues. We're getting vascular stasis, so this static blood begins to accumulate because it's not really passing through anymore. It's just static, it's just a small amount that's there, it's just sitting there. We started to get capillary blockage, and that can lead to a number of conditions. So it can lead to acute tubular necrosis, so one of the many types of acute kidney disease. It can lead to ARDS, so that's acute respiratory distress syndrome, and it can lead to intravascular blockages. And finally, if we're looking up in the top right again, we've got this minimal peripheral tissue perfusion. Means we get the tissues are thinking we're getting this, we're not getting enough nutrients, so you get this local vasodilator release, increasing endothelial permeability, which then potentially leads to this loss of protein and fluid into the interstitial fluid, because of course they're becoming more gaping, so endothelial gaping and increase in permeability. Therefore, we get a reduction in our oncotic pressure, meaning the fluid now moves from the plasma into the interstitial fluid, which isn't so useful. We're getting a reduction in that oncotic pressure, we're getting a loss of that protein and fluid into the interstitial fluid, reducing that oncotic pressure, therefore reducing blood volume and blood pressure even further. And fluid loss can be further amplified, for example, when albumin and other proteins are consumed for fuel, therefore reducing that oncotic pressure and therefore further reducing blood pressure. And fluid leaking into the interstitial fluid, leading to that edema, can actually be very nasty, of course, because in particular, if you're thinking about pulmonary edema, because it makes it harder to breathe and get that oxygen in. So you can see how all these mechanisms, while they look quite complex, actually flow on from one into the other, all leading to this vicious cycle of shock becoming worse and worse until it eventually becomes irreversible if it hasn't been appropriately treated. So when that mean arterial pressure becomes very low, so less than 50 millimeters of mercury, the brain stimulates the CNS, what's called the CNS ischemic response. So this is basically a last-ditch attempt by the brain mediated by brainstem neurons to increase arterial blood pressure by intense sympathetic vasoconstriction, and it's called the CNS ischemic response. It often fails and the patient dies when it gets into this significant part, but it's this kind of this last attempt by the body or by the brain to survive, if you like. You get intense vasoconstriction from the sympathetic nervous system induced ischemia by these brainstem neurons. And in severe shock, many organs are affected. The liver and kidney usually have significant damage. This compromises liver and function on recovery if people do recover. There's also a lot of inflammatory damage to the lung tissue that often takes place. And that can obviously develop into ARDS, so adult respiratory distress syndrome. It's also called shocked lung syndrome if shock is the cause. And that can lead to acute respiratory failure and potentially death. And this usually occurs due to pulmonary cytokine release, impaired endothelial barriers, as occurs in shocks, loss of surfactant and fluid accumulation, and mortality due to ARDS is somewhere in the region of 20 to 50%. So finally, just a couple of review questions for you. So the pathophysiology of shock is quite complex, and but it's good for you to try and understand what's happening and what's happening at each of the different stages of shock. So have a look at these questions and then we'll go through them. So press pause. Okay, so the first compensatory response to shock is which of the following? Is it 1, 2, 3, or 4? Well, hopefully you put 4, an increase in cardiac output, because obviously numbers 1 and 2 aren't compensations, so a reduced venous oxygen saturation and a fall in blood oxygen content, they are not compensatory responses. And an increase in respiratory rate tends to kick in a little bit later following metabolic acidosis, for example. So it isn't in that first compensatory response, it's that cardiac output change. What characteristics distinguish septic shock from hypovolemic shock and cardiogenic shock? So only one of these is correct. Is it 1, 2, 3, or 4? I shouldn't have told you that, should I? So septic shocks will present with cool skin due to vasoconstriction. That's incorrect, because septic shock can lead to vasodilation, obviously, and warm skin. Patients with septic shock will have a bluish color to their skin. Obviously, that's going to be incorrect as well. Number 3, vasodilation will lead to warm, flushed skin in septic shock patients. Yes, that's correct. And septic shock patients do not have a metabolic acidosis. That's obviously going to be incorrect. I wasn't very smart there, was I? I kind of gave you the answer before we started. Oh well, never mind. Hope you enjoyed. Bye.